Welcome back to Medical Study 19. Today we are going to discuss a very important gynecological topic, abnormal uterine bleeding or simply AUB. Abnormal uterine bleeding is one of the most common reasons why women visit gynecology clinics, especially during their reproductive and perimenopausal years. It refers to any kind of bleeding from the uterus that is irregular in volume, duration, or timing and is not related to normal menstruation. Understanding AUB is important not only for medical students and doctors but also for general awareness because it can be a sign of various underlying conditions ranging from hormonal imbalance to serious pathologies. So in this lecture, we'll break it down step by step: definition, classification, causes, clinical features, investigation, and management. Let's get started. This is the outline of this lecture: definition, classification, and pathology, diagnosis, treatment of acute and chronic AUB. Now, what actually is abnormal uterine bleeding? One of the most common health concerns of women, can present in many ways, from infrequent episodes or oligomenorrhea to excessive flow, heavy menstrual bleeding, or prolonged duration of menses and intermenstrual bleeding. This lecture will focus only on heavy menstrual bleeding. Now, what actually the normal menstrual blood flow is? The mean duration of the menstrual cycle is 28 plus minus 7 days. Average menstrual blood loss is 35 ml and normal value ranges from 10 to 80 ml, and average number of days of menses is 4 days and normal ranges of 2 to 7 days. Now, abnormal uterine bleeding is abnormal, heavy or heavy if it occurs at interval of 21 days or less or 35 days or more and lasts longer than 7 days and massive blood loss of 80 menstrual blood loss of 80 ml or greater. The term dysfunctional uterine bleeding is no longer favored and should be discarded. Now, palm coin classification of AUB by FIGO, International Federation of Gynecology and Obstetrics. Here, P means polyp, adenomyosis, leiomyoma, malignancy and hyperplasia, and submucosal. C means coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and N means not yet classified. Diagnosis nomenclature. The acronym AUB is followed by the letters PALM, COEIN, and a subscript 0 to 1 associated with each letter to indicate the absence or presence, respectively, of the abnormality. For example, if a patient with abnormal bleeding due to polyp came AUB P1, A0, L0, M0, C0, O0, E0, I0, N0. A0 represents the negative cause and the patient with AUB was the cause of AUB in a patient was only polyp. In the same way, in the second example, the cause was malignancy and ovulatory dysfunction. Here 1 and 1 indicates the positive cause responsible for AUB. And endometrial polyps, AUBP, means it is localized overgrowth of endometrial tissue containing glands, stroma, and blood vessels covered with epithelium, most commonly found in reproductive age women, and estrogen stimulation is throughout to play a key role in their development. Usually it is benign, and women with symptomatic polyps can be treated safely and effectively with operative hysteroscopy. Adenomyosis, simply also known as AUBA. It is the presence of endometrial glands and stroma in the uterine myometrium cause ectopic endometrial tissue, and that leads to hypertrophy of the surrounding myometrium. The risk factors are multiparity and any process that allows for penetration of endometrial glands and stoma past the basal layer, for example, dilation, curettage, cesarean delivery, spontaneous abortion. Another enlarged asymmetrical uterus on ultrasound is seen. Abnormal bleeding due to adenomyosis is thought to be a result of altered uterine contractility and is associ- associated with profound dysmenorrhea. Lipoma or AUBL, also called fibroids, are benign tumors of uterine myometrium. The pathogenesis is myometrium injury leading to cellular proliferation, decreased apoptosis, increased production of extracellular matrix, and overexpression of transforming growth factor beta that leads to fibrosis of these tumors. And mechanism by which fibroids cause abnormal bleeding are varied and depend on size, location, and number of intracavity or submucous fibroids, whether it is intramural fibroids or subserous fibroids. Then what is the management? The management is medical management and in surgical hysterectomy and myomectomy. Malignancy, also known as AUBM, when vulvar, vaginal, cervical, endometrial, uterine, and adnexal cancer. Bleeding from cervical malignancy classically presents as coital bleeding or intermenstrual bleeding, most secondary to prolonged exposure to hyperestrogenic state, also known as chorionic anevolution or PCOS, obesity, nulli gravidity, etc. Lynch syndrome or hereditary non-polyposis colorectal cancer is an autosomal dominant disease caused by a disruption in the mismatch repair genes carries a 40% to 50% lifetime risk of endometrial cancer, mostly before the age of 45. This may occur. And estrogen producing ovarian tumors, for example, granulosa theca, Seltz tumor, coagulopathy or AUBC, the disorder of blood coagulation, such as von Willebrand disease, which is most common, prothrombin deficiency, hemophilia, leukemia, severe sepsis, idiopathic thrombocytopenic purpura, and hypersplenism. The routine key screening mainly indicated for the adolescents who has prolonged heavy menses beginning at menarche. In adults, screening of this disorder indicated by clinical signs such as bleeding gums, epistaxis, or ecchymosis. The other disorder that produces platelet deficiency, such as chronic anticoagulation as a result of heparin, low molecular weight, heparin direct thrombin inhibitors, and direct factor XA inhibitor. Adults with heavy menstrual bleeding and history of either one of the following means either postpartum hemorrhage or surgical bleed or dental bleed, or two of the following means bruising size more than 5 centimeter, epistaxis 1 to 2 times a month, whether there is a gum bleeding or family history of bleeding. For testing of these categories, we will perform CBC test, PT test or PTT test, VWF antigen, and ristocysteine cofactor. Diagnostic approach to adults with abnormal uterine bleeding due to coagulopathy. It is the structural diagram for diagnostic approach. Now, ovulatory dysfunction, also known as AUBO. The predominant cause of ovulatory dysfunction, postmenarchal and premenopausal woman, is secondary to alternation in neuroendocrine function. There is a continuous estradiol production without corpus luteum formation and progesterone production, continuously proliferating endometrium, which may outgrow its blood supply and results in necrosis. Uniform slow to the basalis layer does not occur, which produces excessive uterine bleeding. Ovulatory dysfunction AUBO. In ovulatory bleeding occurs most commonly during the extremes of reproductive life in the first few years after menarche and during premenopause. In the adolescent, an ovulation is due to an immaturity of SPO axis. SPO axis means hypothalamic pituitary ovarian axis and failure of positive feedback of estradiol to cause a luteinizing hormone surge. In the perimenopausal woman, lack of synchronization between the components of the SPO axis occurs as the woman approaches ovarian decline at menopause. Again, the patterns of an anovulatory bleeding may be oligomenorrhea, intermenstrual bleeding, or heavy menstrual bleeding, HMB. What are the causes of an ovulation? Extremes, extremes of reproductive life, if there is if the female is suffering from PCOS, polycystic ovary syndrome, hypothalamic dysfunction related to weight loss, severe exercise, stress, or drug use, anemia may also be the cause responsible for ovulatory dysfunction. Abnormalities of other non-reproductive hormones like thyroid hormone, prolactin, and cortisol. Iatrogenic AUBI means it is the abnormal bleeding resulting from medication. Most common of these are hormonal preparations including selective estrogen receptor modulators and gonadotropic releasing hormone agonist and antagonist. Hyperprolactinemia can result from central nervous system dopamine antagonism of certain antipsychotic drugs like risperidone. Combined and progesterone only oral contraceptive may result in breakthrough bleeding. BTB means breakthrough bleeding. Interaction between oral contraceptives and other medications such as antibiotics and anticonvulsants may alter circulating level of steroids, allowing follicular recruitment and increased endogenous level of estrogen. Endometrial AUBE. Heavy menstrual bleeding is the absence of other abnormalities throughout to the underlying disorder of endometrial or otherwise unclassified. In the past, this category has been called ovulatory dysfunctional uterine bleeding. The primary line of defense to excessive bleeding during normal menses is the formation of platelet plug, followed by uterine contractility, largely mediated by prostaglandin F2 alpha, also known as PGF2 alpha. Thus, prolonged and heavy bleeding can occur with abnormalities of the platelet plug or inadequate uterine level of prostaglandin F2 alpha. In some women with heavy menstrual bleeding, there is excessive uterine production of prostacyclin and vasodilatory prostaglandin that opposes platelet adhesion and may also interfere with uterine contractility. Deficiency of uterine prostaglandin F2 alpha or excessive production of PGE vasodilator prostaglandin may also explain an ovulatory GUB. This low prostaglandin alpha or PGE will increase the menstrual blood loss. AUBN, also known as not otherwise specified. Abnormal bleeding not classified in the previous categories is considered as AUBN. Examples of such condition may include foreign bodies or trauma. Treatment is tailored to the specific cause. And diagnostic approach. History taking is most important. Physical examination and laboratory exams. Now, medical history, menstrual history, frequency, duration, and amount of bleeding should be taken. Inquire whether and when the menstrual pattern changed. Describe the menstrual abnormality as oligomenorrhea, polymenorrhea, heavy menstrual bleeding, or intermenstrual bleeding. Menstrual calendar to record her bleeding episodes. Helpful way to categorize definitely the bleeding episode. Symptoms present for majority of preceding 6 months are considered chronic. Now the menstrual history for all patients, age at menarche, cycle of length, duration of bleeding, precision of flow, heavy, medium, or light, menstrual product use, first step, LMP, and dysmenorrhea should be enlisted, should be asked to the patient. The menstrual calendar for remembering the episodes of menstrual bleeding. The, for the patient reporting heavy menstrual bleeding, whether it lasts for more than 7 days or not, sucking through pads or tampons in 1 hour for 2 to 3 hours in a row, whether there is requirement of frequent pad or passing blood clots with is more than or equal to 1 inch in diameter above the size of water. For patients reporting heavy menstrual bleeding, continue same. Whether using double protection like pad plus tampon or two pads together, flooding or gushing sensation, frequent accident or leaking through protection, hemorrhage from corpus luteum, diagnosed with anemia, and associated with history of excessive bruising or bleeding or family history of bleeding disorder should be taken. And medical history, whether patient is suffering from epistaxis, which is more than 10 minutes or requiring medical attention, spontaneous bruising, which has size more than 2 centimeter, or minor wound bleeding for more than 5 minutes. Bleeding from oral cavity or GI tract without an obvious anatomical lesion, prolonged or excessive bleeding after dental extraction or surgery, hemorrhage that required transfusion of the patient should be taken clearly. Similarly, social history like social stressors, substance use, and exercise patterns and athletic competition should be taken. Family history like bleeding disorder, menstrual disorder, diabetes, and thyroid should be taken in consideration. And past medical history, symptomatic illness, including hematological or renal disease, and current or recent medication should be taken in mind. And medical history like sexual history, what contraception and whether they use contraception or condom, number of partner, history of sexually transmitted infection or current symptoms like vaginal discharge, pelvic pain, previous pregnancy or abortion, history of sexual abuse or assault should be taken clearly. In physical examination, vital signs such as tachycardia and hypotension may signal acute hemodynamic instability and the need of rapid intervention. The presence of tachycardia, pallor, or a heart murmur suggests anemia. Physical examination, petechia or excessive bruising may suggest a platelet defect or another bleeding disorder. Obesity, acne, hirsutism, and acanthosis nigricans may be present in the patient with PCOS. You can see in the figure a palpation of thyroid gland for enlargement or other abnormalities, examination of the optic fundi and visual field testing for pituitary tumor, sexual maturity rating of the breast and assessment of galactorrhea, palpation of the abdomen in case of pregnancy, uterine or ovarian masses, whether there is a presence of external inspection of the genitalia is sufficient for diagnosis in most patients. A sexually active patient may warrant a complete pelvic examination, such as speculum and bimanual examination, digital examination, and laboratory evaluation. Pregnancy test should be done. Complete blood count, including differential and platelet count, blood typing, measure of iron stores, prothrombin time, and activated PTT means partial thromboplastin time should be recorded. Von Willebrand studies shows factor 8, factor 9, Willebrand factor antigen W, VWF, AG, and ristocystine cofactor VWF RCO activities. TSH test for chlamydia, trichomoniasis, and Neisseria gonorrhea, and pelvic ultrasound are done. Patient with history of amenorrhea or irregular bleeding prior to the onset of heavy bleeding should have FSH and LH, total and free testosterone level, dihydro epiandrosterone prolactin level should be checked. Now treatment. In management, the management of AUB depends on assessment of whether or not the patient is hemodynamically stable. Determination of the underlying cause, medical management based on etiology and the severity of anemia. The goals of treatment are to establish and maintain hemodynamic stability, to correct acute or chronic anemia, to return to a pattern of normal menstrual cycle, to prevent of recurrence, prevent long-term consequence of anovulation, anemia, infertility, endometrial cancer. And medical treatment. The goal of medical therapy is to stabilize the endometrial with estrogen that will provide initial hemostasis followed by progesterone for endometrial stability. Typically, this is achieved with combined oral contraceptive pills (OCPS) taken continuously for several months until hemodynamically stable, as withdrawal of either hormone will cause recurrent bleeding. And medical treatment. Episode of moderate to severe bleeding can typically be treated effectively with frequent dosing of combined oral contraceptive pills. Treatment. In the absence of organic cause for excessive uterine bleeding, it is preferable to use medical instead of surgical treatment, especially if the woman desires to retain her uterus for future childbearing or will be undergoing natural menopause within a short time. The type of treatment depends on whether it is used to stop an acute heavy bleeding episode or is given to reduce the amount of massive menstrual bleeding loss in subsequent menstrual cycles or chronic AUB. A definitive diagnosis is required before initiating long-term treatment and should be made on the basis of hysteroscopy, sonohysterography, or directed endometrial biopsies. Abnormal uterine bleeding. A. Adolescence. After ruling out coagulation disorder, the main direction of therapy is to temporize because once the HPO axis matures, the problem will be corrected. And cyclic progesterone. It is medoxyprogesterone acetate 10 mg for 10 days each month for a few months to produce reliable and controlled menstrual cycles. Oral contraceptive pills may be an option if the problem persists beyond 6 months. For the P. Perimenopausal woman. The low dose of about 20 μg combined oral contraceptive in non-smoking women should be given for psychological progesterone. Reproductive aged woman. Chronic anovulatory bleeding is primarily caused by hypothalamic dysfunction or PCOS and abnormal uterine bleeding for endometrial. For women with heavy menstrual bleeding, for whom there is no non-cause and anatomical lesion have been ruled out, the aim of therapy is to reduce the amount of excessive bleeding. Some women with AUB have abnormal prostaglandin production and some have alteration of endometrial blood. Option for treatment is to reduce blood loss include prolonged regime for progesterone of about 3 weeks each month, and oral contraceptive pills will reduce the blood loss by at least 35% in abnormal uterine bleeding. Non-steroidal anti-inflammatory drugs. Prostaglandin synthase inhibitors that inhibits the biosynthesis of cyclic endoperoxides, which convert arachidonic acid to prostaglandins, block the action of prostaglandin by interfering directly at the receptor sites. All NSAIDs are cyclooxygenase inhibitors and thus block the formation of both thromboxane and prostacylin pathway. Nevertheless, NSAIDs have been shown to reduce MBL primarily in women who ovulate. For example, mefenamic acid of 500 mg 3 times daily should be given, ibuprofen of 400 mg 3 times daily, and naproxen sodium 275 mg every 6 hours can be given in the first 3 days of menses or whole duration of menses. Antifibrinolytic agents. E-amino caprioic acid, tranexamic acid, and para-amino methyl benzoic acid are potent inhibitors of fibrinolysis. Their use is somewhat limited by side effects. Gonadotropin releasing hormone agonist. GnRH agonist may be used to inhibit ovarian steroid production, as estrogen production is necessary for endometrial proliferation. Because of the expenses and menopausal side effects of these agents, their use is limited to women with severe MBL, massive menstrual bleeding loss, who fail to respond to other method of medical management and wish to retain their childbearing capacity. More commonly, GnRH agonists are an effective means of bridging patients to surgical treatment, allowing for correction of anemia. Use of an estrogen or progesterone at back therapy. Management of acute bleeding. Acute AUB in women who are bleeding heavily and are hemodynamically unstable. The quickest way to stop acute bleeding is with curettage. Curettage should also be the preferred approach for older women and those with medical risk factor for whom high dose hormonal therapy may pose a great risk. May also be managed medically with pharmacological agents. Pharmacological agents for acute bleeding. To stop acute bleeding that does not require curettage and most effective regime involves high dose estrogen. High dose estrogen is aimed to stop acute bleeding and is merely a temporary measure. Estrogens. Estrogen in a pharmacologic doses cause rapid growth of endometrium. A rapid growth of endometrial tissue occurs over the denuded and raw epithelial surfaces. Large dose of estrogen may alter platelet activity, thus promoting platelet adhesions. Oral conjugated equine estrogen (CEE) 10 mg per day in 4 divided doses. Intravenous conjugated estrogen 25 mg every 4 to 6 hours until the bleeding stops. No more than 6 doses should be administered. And a combination of oral contraceptive, both estrogen and progesterone. 4 tablets of an oral contraceptive containing 30 to 35 mg of estrogen taken every 24 hours in a divided dose. Progesterone for the patient with contraindication of to estrogen, uh, it can be given. Progesterone not only stop endometrial growth but also support and organize the endometrium so that an organized slough occurs after their withdrawal. With progesterone treatment, an organized slough to the basalis layer allows a rapid cessation of bleeding. Progesterone stimulates arachidonic acid formation in the endometrium, increasing the prostaglandin F2 alpha or PGE ratio. And medroxyprogesterone acetate MPA at the dose of 60 mg daily of 20 mg 3 times daily for 7 days followed by 20 mg per day for 3 weeks is given. And depot MPA means medroxyprogesterone acetate 150 mg intramuscularly followed by oral MPA 60 mg of 20 mg 3 times daily for 3 days is given. Androgens. Danazol is synthetic androgen used in doses of 200 mg daily for the treatment of heavy menstrual bleeding. Limited use because of side effects of weight gain and skin problem. Indication for hospitalization. Hemodynamic instability if there is tachycardia and hypotension, severe hypotension, hemoglobin concentration less than 7 gram per del or less than 10 gram per del with active heavy bleeding, symptomatic anemia like fatigue, lethargy, need for intravenous conjugated estrogen, example cannot take oral medication, continued heavy bleeding after 24 hours of estrogen progesterone combination therapy, and need for surgical intervention is rare. Surgical management of acute AUB. Dilation and curettage, both diagnostic and therapeutic for the immediate management of severe bleeding. For women with mildly excessive uterine bleeding who may be hypovolemic, dilation and curettage is the quickest way to stop acute bleeding. Treatment of choice in hypovolemic women. Dilation and curettage may be preferred as an approach to stop an acute bleeding episode in a woman older than 35 when the incidence of pathologic findings increases. Dilation and curettage is only indicated for women with acute bleeding or resulting in hypovolemia and for older women who are at high risk of having endometrial neoplasia. All other women after having an endometrial biopsy sonohysterography or diagnostic hysteroscopy to rule out organic disease and best treated with medical therapy without dilation and curettage. Endometrial ablation. If medical therapy is not effective or is contraindicated, it can be performed. Exception are women who have very large uteri caused by fibroids or abnormal pathology such as endometrial hyperplasia or cancer, and alternative to hysterectomy. This is hysterectomy. Surgical removal of uterus known as hysterectomy, reserved for women with other indication for hysterectomy such as leiomyoma or uterine prolapse, usually offered to women with completed family size, no longer desire of pregnancy, and used to treat persistent abnormal uterine bleeding after all medical therapy has failed or medical therapy is contraindicated. Chronic AUB. Multiple treatment options are available for prompt treatment of chronic AUB. Levonorgestrel intrauterine system, OCS, monthly or extended cycles, progesterone therapy, oral or intramuscular, and tranexamic acid and NSAIDs can be given. So that was a detailed overview of abnormal uterine bleeding. We learned that AUB is not a disease itself, but a clinical symptom with multiple possible causes categorized under the palm coin symptom. Timely diagnosis, proper investigation, and management are essential to improve quality of life and to prevent complications like anemia or, in rare cases, malignancy. Remember, when a woman presents with abnormal bleeding, it's always important to evaluate carefully. Never ignore the symptom. Thank you for watching Medical Study 19. If you found this lecture helpful, don't forget to like, share, and subscribe to our channel for more medical study topic explained in simple language. See you in the next lecture.